topic is about, we're going to talk about spleen and liver, and we're going to talk about those things that you find while you're scanning and you're doing your fast exam and you see like the liver looks like Swiss cheese, or there's something funky in the spleen, or what's going on, why are there these little knobby things in the liver? So this is kind of a series of cases that I've had over the years, and we'll talk about kind of normal and what's not normal, and sort of develop some limited differentials for those abnormal things that you find. Conflict of interest, I have none. So our objectives, and I have to put these up, but basically what's normal, and then what's abnormal, and develop a limited differential for those abnormal findings for both the liver and the spleen. So the liver anatomy, I can use my little mouse here. Okay, so the liver, I'm not going to go into all of the different segments and all of that sort of stuff, but you should know that it's divided into the right lobe and the left lobe. And the right lobe actually has an anterior and a posterior segment, and the left lobe has a medial and a lateral. And the two halves are divided by the falciform ligament. And that's actually a really important landmark, because if you follow that, it actually takes you right into the gallbladder fossa and right into your portal triad. You'll also notice on the bottom of the liver that you have a space for the colon and also for the kidney on the bottom half of the liver. And remember that the top half is all covered by diaphragm, and then you have fascia over the liver, except for this little area called the bare spot. So I love this picture because the spleen looks like it's it's really tiny. It's not quite anatomically correct, I don't think. But the liver, which is what we'll focus on first, the important thing here is to take a look at the circulation. So the hepatic veins, which drain the liver, they drain into the IVC, and there's three of them. There's the right one, which actually divides the anterior and posterior segments. The left one divides the medial and lateral segments of the left lobe, and then this middle one comes right down through. And actually, if you look at them coming off the IVC or going into the IVC, usually the middle vein actually comes off of this left vein. So those are the blood vessels that are draining the liver. And then we have the portal triad. So we have three different two vascular and one bile structure, and they all travel together well into the liver. So there's the common, and then they break up into the left and the right. And you'll see all of these structures kind of going along with each other, and you can pick them up. And normally we can see like the common bile duct, and you can see it branching off into the portal structures into the left and the right. And then it kind of gets to the point where you really don't see it in the liver. I mean, we'll talk about what that means when you do see it.
Any available medic that's not busy, please.
Okay, I don't know who that is, but perhaps mute. So we're going to scan so this is the sagittal view, and we're scanning from the patient's right to the left. And I was planning to update this with some little images and all of that, but I was telling Matt I spent the morning in IS because my VPN connection isn't working, and they were playing with my computer for hours, and then they've decided that they have to wipe it. So I said, actually, I need it for a little while. So I didn't get to update this as much as I wanted to. So scanning through from right to left, and we start, and this is a little echogenic because the last time I did this, it was in a light room. So you can see the portal triad coming together, the portal veins coming together into the common one. We have the IVC, and you can actually see the hepatic vein coming in to drain it. Nice IVC going along. You'll get over more medial. We have the aorta, and then you actually have your celiac axis, and then your SMA going into that. And all along, all of this is the liver up here, and it just keeps going and going and going until you're actually past the midline, the aorta's out of view, and then the liver will finally end. So that's kind of the normal appearance of the liver. So it's kind of homogeneous. It's broken up by the portal triads and the hepatic veins. And then this is the transverse view. So we're starting angling up towards the heart. So you can actually see this is the right atrium. And as we scan, now you're scanning, so you're pointing the transducer, we're angling down towards the patient's back. And you can see the hepatic veins come into sight here. And you can actually see that that middle vein is smaller and it's actually coming off of the left one. So your hepatic veins, as they drain into the IVC, and you'll actually see your portal vein breaking off. There you go. And now we have our portal triad structures here. Your portal triad with your hepatic artery. And just scanning all the way through. So nice, normal liver. So your sagittal view and your transverse view. So if you had to describe this, would you say it's the parenchyma is homogeneous, inhomogeneous? What do you think? Let's see who all's out there. Maybe our medical students can chat, you can talk. Don't make me feel like I'm alone. Homogeneous, anyone? Yes, hopefully. Okay.
Sure. We'll go with homogeneous.
All right, sounds really good. All right. So the chat box here. Okay. So it's normally very homogeneous. It's interrupted by the portal triads and the hepatic veins, and it's pretty smooth. It doesn't look knobbly. What about the echogenicity? Is it, when you guys scan, think about this, is it more echogenic than the kidney or is it less echogenic? Anybody want to chime in? Chat box? Talk? Yes, it's about the same. And how about for the pancreas? Which is more echogenic? Here's somebody typing, maybe. I don't know. Oh, there we go. Liver is more echogenic. Actually, so the liver is typically, its echogenicity is greater than or equal to the right kidney. And typically they're about the same. I suppose if you really looked at it, you could see the difference. And then it's hypoechoic compared to the spleen and the pancreas. And normally we're not scanning the liver and the spleen at the same time, so you're probably not comparing them. But the pancreas is going to be more echogenic than the liver. So we have our nice normal liver here. How about the size? Anybody know what normal is? So you're scanning and you're thinking, wow, that liver is big. How do I know if it's too big? I'm going to say we probably don't all know, but it's actually 13 to 17 centimeters. And the place you measure this is in the midclavicular line. So you line your transducer up in the sagittal view and measure it in the midclavicular line. And it should be 13 to 17 centimeters in an adult. I have no idea about the pediatric population. So hepatomegaly is described as if it extends beyond the lower pole of the kidney. And normally when you scan that inferior tip at the kidney, it's pointy, right? When you're doing your FAST exam, it looks kind of pointy. If it's rounded there, that can be considered one of the components of hepatomegaly. And also if the left lobe actually extends into the left upper quadrant over the top of the spleen, that is considerable hepatomegaly. So here we have a nice liver. You can see it's measured, and this is in the midclavicular line, and it's 11.2 centimeters. So that looks pretty nice. So this is an example. You can have an accessory lobe. So you would look at this and you would say, wow, this liver is really big. Except that if you come into the midclavicular line, it's probably not too big. And this is an accessory lobe. Does anybody know what this is lobe, this little guy right here is called? I might bring you a cookie if you know. Oh, Bob, you don't count.
Oh, right.
Okay, you can come and get a cookie if you want. It's a Reidel's lobe. So this is a normal anatomic variant. And this lobe can actually go all the way down to the iliac crest as it does in the CT. So these can be really long. But the rest of the liver isn't enlarged. It doesn't really cross over to the left side. It's not long here. It's just this long extension of the right side of the liver. And that's called the Reidel's lobe. All right, so once again, we have our nice normal liver. And then what about this one? Compare it to this view. What do you notice about that one? I'll kind of video through here. All of this stuff. How about all of these tubes? Does it look like there's too much anechoic space in here? Yes, it does. So if you have too many tubes or too much vascular appearing stuff in your liver, you have to figure out, is it veins? Is it artery? Is it bile system? So if it's the bile ducts, one of the ways you can figure this out is to put color on it. And this is going to be the most commonly dilated structure, is typically going to be your bile ducts from some type of obstruction. So you can see by putting color on it that you can prove that this is actually the bile ducts, the intrahepatic ducts that are dilated. So this might be an abnormal thing that you'll find on somebody. You're scanning for their gallbladder and you're looking at the liver and you're thinking, oh, wow, these are kind of fat. There's too many of them. I'm going to put some color flow on this, and I'm going to see if I can tell if it is the intrahepatic ducts. So the criteria for whether these are dilated or not, if they're bigger than 2 millimeters in diameter, it's considered intrahepatic biliary duct dilatation. You can also use 40% of the diameter of the adjacent portal vein. I find it hard to get the two really in line together. I think the 2 millimeters is actually an easier way to find this. And then they say if you have increased through transmission from these bile structures, because again, they're anechoic fluid. Again, I don't find that as useful as the bigger than 2 millimeters in diameter. And also if they're irregular and have tortuous walls. So you'll notice that they may have a stellate configuration centrally as they come together into the left and the right portal come together, and a lack of a Doppler signal as well. And this is kind of an example of that stellate configuration as they come together. You can see it looks kind of like a star pattern. So there's like a nice star there. And then you would put color on that and you could readily see that they were, that it's bile ducts as opposed to vascular structures. So why can your intrahepatic ducts be dilated? What's probably the most common thing?
Sclerosis.
You might see it in sclerosis. So what happens in sclerosis that causes them to be dilated? There's usually some kind of compression. So it's usually there's a mass, whether it's a stone or something else within the bile system, so like in the common bile duct, or you can actually have an extrinsic mass as well. So choledocholithiasis is probably the most common thing that's going to cause this. You can have a stricture, so something congenital or something that causes a stricture, or a mass if you have a tumor that's close to the bile duct that's compressing it from the outside, or a tumor that's inside of it that gives you this biliary dilatation. And these people may be jaundiced and all of that good stuff too. All right, so back to our nice normal liver. What's next? Oh yeah, okay, so our nice kind of normal liver. Then what about this liver? What do you notice? What's like all of this stuff? Bright echoes, dirty shadowing, air. Exactly. Thank you, Matt. And what else do you notice is going on in this image? So there's air here, and what do you have right here? Kind of filling up the space here, not really the shape of a gallbladder. It could, yes, it's ascites. It's free fluid. And you know what exactly the cause is hard to say. What if I told you that this person has a perfed viscus? So where do you think all this air is? It's in the biliary tree. So this is actually from a perfed viscus. So these are actually, the air is in the biliary tree. It's not in the veins themselves. It could be if you had some kind of gas forming organism that was causing air in the veins. But this is actually in the biliary tree. So it's coming up through the gut and through this perfed viscus and getting into the biliary tree. So that would be, that's a kind of a bad finding that hopefully you won't see, but you want to recognize it if you do. So air within the liver parenchyma, and it's going to give you those small little micro foci of hyperechogenicity with kind of this shadowing behind it. And you can actually see that there's a considerable amount of air right where the the common bile duct is coming together. It's hard to really see all the landmarks, so lots of air there. All right. So if you're looking for the intrahepatic ducts, we're looking at the parenchyma, and if you notice that they're enlarged, you're going to kind of look at the general appearance, too many tubes, the comparison to the portal veins, and then use some color Doppler. And then you also want to be thinking about the presence of air. So is there little microfoci within the liver? If you see that, that's something that you don't want to miss, because obviously it's a predictor of bad stuff. So this is a 60-year-old male. He's hypotensive. He's got some diffuse abdominal tenderness. Maybe it's greater in the right upper quadrant. What do you think about this liver?
I don't know.
Is it kind of homogeneous or not homogeneous? Yeah, it's not homogeneous. And Bob asked about pneumobilia or portal venous gas. That's actually pneumobilia in there, in that image, the one we were just on. So this liver is inhomogeneous. And there are several things that can cause that. So it's diffuse. It's not just one area that's inhomogeneous. The common things that can cause this are cirrhosis, fatty infiltrate, and metastatic disease. But there's some uncommon things too. So carcinoma can cause it, fibrosis, and lymphoma. So this is when the liver just appears diffusely inhomogeneous. I want to talk a little bit about cirrhosis. So because cirrhosis is something we see pretty commonly, and it will give you that diffuse inhomogeneity, and also you can have some knobbly edges. So with liver cirrhosis, there's some ascites here, but you can also see that the liver has a real nodular appearance. And that's going to be really common in cirrhosis. But you can also just have diffuse fatty infiltrate. So the normal liver appearance, it's kind of this dark purple. As you progress through the fatty infiltrate, and this can be caused by cirrhosis, and it can also be just caused by fatty infiltrate, the non-alcoholic type. So the liver, the color changes a little bit, and then you can get areas of fatty infiltrate. So you may find that there's areas in the liver, you can actually have a wide distribution of the fatty infiltrate, and then have areas of sparing. And then when you progress, you get to just completely fatty infiltrate and this nodularity of cirrhosis. So with the areas of sparing, and this can be hard to figure out, is the whole liver fatty, or is are they just the areas of fatty of sparing? So this would be a fatty liver, and you'll notice that it's really more echogenic now than the kidney, because fat tends to be more echogenic, and it also loses its nice crisp appearance of the vascular structure and the portal structure. So it becomes much more echogenic, and you lose that nice crisp appearance of the structures. And then this is an example. So the liver is full of fatty infiltrate, but right near the gallbladder, you have this area of fat sparing. So this is actually normal appearing liver, and this is really common, and this is a very common area that you'll see this it's basically the sparing of the fatty infiltrate. But you can also have where the liver is pretty normal, and then have areas where you have focal fat infiltrate. So this is actually an area of sparing. The whole liver is fatty, and then there's this area of sparing near the gallbladder. And this, on the other hand, is a pretty normal liver, so you would expect it to be the same echogenicity as the kidney, and then you have this area of fatty infiltrate. Now, can I necessarily say, oh, that's fatty infiltrate and not some kind of bad tumor? No, I probably wouldn't be sure, and I would be making sure I got somebody else to take a look at this. But one of the things that you'll notice is that it doesn't have nice firm borders. It's kind of messy, so it's probably it's not like a nice cystic lesion, not like a nice adenoma where you're going to have a nice boundary. It's got this kind of wavy boundary. I'm not sure that it's self-contained. So this would be something that I would want somebody else to look at, but this is an area of focal fatty infiltrate in an otherwise normal liver. whereas this is an area of fat sparing in an otherwise fat infiltrated liver. This is just another example of, so the gallbladder is here, and you'll notice you have a really hard time seeing all of the structures in this image, but there's this funny thing right next to the gallbladder. This is another example of fatty sparing. So this is an area of focal fat sparing in an otherwise really fatty liver. Hard to see the structures, kind of echogenic, and then it has this nice area of focal fat sparing. So fatty infiltrate is typically hyperechoic. You have a hard time seeing the normal structures. This is the liver that you're looking at, and you're like, why can I not find the common bile duct? Why can I not see the gallbladder? Why can't I see the vascular structures? And then you'll notice that it's hyperechoic compared to the kidney, and that would be an example of a focal or a fatty infiltrate. And then you can have focal areas of either fat infiltrate or sparing, and these are typically in the gallbladder fossa along the falciform ligament and in the porta hepatis. And they usually have pretty poor margins. They don't have any mass effect. And then that geographic location, that typical area in the gallbladder fossa. Again, though, if you're seeing this and this person hasn't had a CT or a prior ultrasound, this is somebody that you want to make sure that you get confirmation that that's actually what you're looking at. So a formal ultrasound or a CT scan would be helpful in making sure that you're not missing some kind of mass there. What kind of lesion? So this is the liver. It's a, we're in the sagittal view. Actually, I think we're in transverse view. What kind of lesion is this? It's round, it's anechoic, it's pretty small. It's got this nice area of through transmission. Yes, it's a cyst. So this is a nice example of a simple cystic lesion within the liver. So it's got nice boundaries, a well-defined posterior wall, and it's got good posterior enhancement or through transmission. So compare this cyst. So this is a 62-year-old gentleman. He's got 6 weeks of right upper quadrant pain, and now he's got a fever. He's got an elevated white count, and his LFTs are normal except for his Al cross. Another example of a cystic lesion, but what kind of a cyst is this? Abscess, exactly. So this is a complex cyst, and actually part of your differential would be that it's an abscess, and you can kind of gather from the data that you're provided that this is an abscess because the guy's febrile, he's got white count, all of that good stuff. So if you see a liver that looks like this, so there's multiple cysts within the liver, what might you expect the kidney to look like? Exactly. Excellent, Jacqueline. So this is an example of polycystic kidney disease. And the liver is involved in about half of the people who have polycystic kidney disease. You'll actually see that there are cysts in the liver as well. So multiple cysts, and surprisingly, the liver function stays pretty much normal, and even though they have all of these cysts. I'm always surprised that they have pretty normal LFTs. Kind of makes you think, how much liver do we actually really need to survive? I don't know. So that's polycystic kidney disease. So
hey, Sandy, can you go back to that abscess right before the polycystic?
Yes, I think. I hope. Yeah.
When you do the sweep on that, it almost looks like in the periphery that there's multiple rounded cysts in the periphery. Was there any chance this was echinococcus and that those were like little cysts?
That was thought of, but they weren't. It wasn't, because we thought it was a echinococcal one, but it wasn't. It was just a regular abscess. And I think it's just the boundary of it that you're seeing. It's like the edge of the cyst, but that actually you can see these echinococcal cysts, and they actually get these daughter cysts, and they have like that swirling pattern in the middle, and then they'll have these baby daughter cysts with swirls right next to them as well.
Because we had one of those a couple of years ago that came in with anaphylactic shock as their presentation that ruptured.
I just did something weird. Okay, there we go. Phew. Yeah, and that's a really good thought, because you can get echinococcus here. You can see that. That's one of the the differentials. So cysts, uncommon. Abscesses, you can have a hematoma that looks like a cystic lesion, especially as it progresses. You can have mets that look like cysts. They're typically target lesions, and they're not quite anechoic on the outside of the target middle, but they can appear very cystic. A biloma can give you that appearance, and then the echinococcus as well. So rare things would be an aneurysm or an AV fistula, and there, if you put color on it, you would see that the cyst is actually a swirling blood pool. You can have an adenoma that has become hemorrhagic and looks like a cyst, usually a complex one. And then biliary carcinoma might actually give you a cystic appearance, and it would be connected to the bile system as well. So I want to go back to the liver with the simple cyst, and we're going to continue scanning through it. And what's happening here? So we had a nice simple cyst at the beginning, and then we have these other lesions at the end. So now we have some solid lesions. So this is a great liver because it's got both simple cysts and it's got solid lesions. So here's your cyst on your CT and your solid lesion. And you notice that the boundary here is really well formed. It's a nice round circle. And then this is your solid lesion. It doesn't have quite as nice of a boundary, so it's not clear exactly what it could be. So solid lesions, most of these are going to be hemangiomas. About 7% of adults have them, and about 10% of them have multiple hemangiomas. So you noticed in that scan that there was one large one, and then there were a couple of smaller ones next to it. And most of those will appear like a solid lesion, but if they get bigger, they tend to start looking, they start to look like they're inhomogeneous, and they look a little bit more like Swiss cheese, and those are difficult to differentiate from carcinoma. So the larger ones are typically are more often atypical. Other things that can cause this, you can get focal nodular hyperplasia, which is this kind of weird benign condition of the liver where you get all of the types of tissue that multiplies within these nodules. It's plain old normal liver tissue, but rather than growing in a normal fashion, it becomes nodular. And we don't really know why you get that, and it functions okay, but it can actually look like a solid tumor. And then adenomas are the other ones. Metastatic disease can look like a solid tumor, although more often it's going to have this targetoid appearance. So this is somebody who was actually put in the CDU for chest pain, except that it was sort of right upper quadrant pain. And so scanning through the liver, you can see the gallbladder looks okay, but just anterior to the gallbladder, so in the left lobe, go past the gallbladder, it's really inhomogeneous. You can see it here. So it's like, oh, the gallbladder looks great, but what the heck is this? So I took the images, actually, this was, I think before we were doing PACS, I took the images over to our radiologist, and he said it's either a good OMA or a bad OMA. So either a hemangioma or a hepatocellular carcinoma. So we got a CT with delayed filling, and you could see the hemangioma in the delayed cuts was full of blood. So I'm happy to say that it was a hemangioma. So this is an atypical appearance of a hemangioma. Most of them are going to appear like those solid lesions, but as they get larger, they might look more like a carcinoma. And if you do a CT contrast with delayed imaging, that's going to help you clarify that. But again, if you see something like this when you're doing a gallbladder ultrasound, you got to make sure that you follow up on it. All right, so what do you think of this liver? First, of course, you notice there's some free fluid. I'm just going to kind of scan through. There's one that's really obvious, but there's a bunch of little lesions, like a nice target lesion. So they have a hyperechoic center with not really an anechoic border, but a hypoechoic border around them, and then your rim. So these are going to be target lesions, and as you'll notice in this, oops, that go away. So there's multiple little ones forming, and then this larger one. And that's going to be a typical appearance of METs. METs. Your differential is METs, and hepatocellular carcinoma. So about half of cancers metastasize to the liver, probably because of the portal system. So everything is going to metastasize to your liver as well as your lungs. So if you see multiple lesions in the liver, multiple targetoid lesions, it's probably MET, but it might could be hepatocellular carcinoma. And uncommon, you can also get lymphoma that goes to the liver, that focal nodular hyperplasia that can look like a solid lesion. It can also look like a like target lesions as well. Fungal abscesses can look like that, and adenomas. So liver, normally it's going to be homogeneous. Your typical dimensions measured in the midclavicular line are 13 to 17 centimeters. The intrahepatic ducts, if you have too many tubes, you're going to start thinking about enlarged ducts. They should be, normal ones should be less than 2 millimeters or less than 40% of the adjacent portal venous structure, and you shouldn't see any air. So the liver, if there's diffuse inhomogeneity, it's probably diffuse fatty infiltrate on its way to cirrhosis, but it may also be metastatic disease. It can be carcinoma or fibrosis or lymphoma as well. So if you have somebody who's got one of the systemic fibrosis diseases, their liver can look like that as well. Cystic lesions, the common things, just benign cysts in the liver. If they're simple, if they're small, again, there's something that we're going to make sure we follow up on. If they are complex cysts, they're more likely to be abscesses, hematoma, cystic mets. It could be a biloma or echinococcus. And then rare things, aneurysms, fistulas, hemorrhagic adenoma, or biliary carcinoma. And it's actually nice if you put some color on there, you can actually help differentiate. So liver, the solid lesion, the most common is going to be hemangiomas. They might be adenomas or other benign or malignant tumors though. So again, you have to get follow-up. And then target lesions, really common, Mets. An uncommon lymphoma, focal nodular hyperplasia, and fungal abscesses or adenomas. And now for something completely different. Anybody else old enough to remember Monty Python? All right. So we're going to talk about the spleen. So the spleen lives on the other side of the body. It's on the left side, the left upper quadrant. It's covered by the diaphragm, and it's adjacent to the kidney. It's got a nice little impression for the kidney and also has an impression for the splenic flexure. In the middle of the spleen, you have a really big vascular bundle. So you have the splenic vein, and then you have the splenic artery. And this can get really tortuous as you get older. Mine is probably becoming tortuous, hopefully not too bad yet. And you can get nice aneurysms off of this as well. So little splenic artery aneurysms. And then the nice parenchyma of the spleen. So the spleen is smaller than the liver, and it's really homogeneous. So nice homogeneous texture. And notice that compared to the kidney, it's pretty hyperechoic, and it's actually hyperechoic when you compare it to the liver as well. So this is going to be the transverse view, and here you can see the hilum with those nice big juicy blood vessels in it. So if you have trauma and you pop your spleen off at the hilum, you don't do really well. You can put color on the hilum as well. So the spleen, homogeneous, echogenicity, it's greater than the liver, greater than the kidney, and about the same as the pancreas. And it's shaped like a nice crescent. How big should it be? I mean, when you look at this spleen, what do you think? Is that normal or is that kind of big? What do you think? Just eyeballing it. Is anybody out there? It's big. Yeah, so it's a big spleen. But how do we know what big is and how do we measure it? So the way they say you measure the spleen is you find it in the longest, so the length of the spleen, the longest place, and you measure it from tip to tip. And then you can actually measure it right at the hilum. So you measure it tip to tip, and then you measure it at the hilum, basically from the edge to the hilum. And so there you have a nice normal spleen. Normal is going to be, where is normal? Normal is going to be less than 13 centimeters in length and less than 6 centimeters in depth. So you can see that this spleen is kind of large. There's also some ascites around that spleen as well. So it's really homogeneous. It's pretty echogenic, and it's shaped like a crescent. And normally it's less than 13 centimeters in length. So scanning through this, What do you notice at the tip of that spleen? Right here. Maybe a little bit of free fluid. So one of the reasons your spleen can be big is there can actually be an intracapsular hematoma that looks very much like the spleen and is causing your spleen to be big. So splenomegaly, the common things are kind of the common things that might give you hepatomegaly too. CHF, portal hypertension, leukemia and lymphoma will give you a large spleen. Hepatitis can give you a big spleen. Mono can give you a big spleen. So if you have a young kid and you can feel their spleen, you can throw an ultrasound on it and you can take a look at it and prove that it's large. And then other infections and hemolytic anemias. So like sickle cell patients before their spleen autoinfarcts, they may have a very large spleen. Uncommon things, glycogen storage disease, malaria, myelofibrosis can give you an enlarged spleen. And then if you have an isoechoic hematoma, it may actually look like splenomegaly. So if you have a large hematoma, just a subcapsular hematoma, that can actually mimic splenomegaly. So if you have a trauma patient and they have a big spleen, really take a look and see if there's a small amount of free fluid, or if there's not vasculature in the entire spleen. It may be that there's actually a hematoma there. So what is this?
Oh,
I can't hear. Somebody said something. They're little guys. What kind of tissue do they look like? They're not, yeah. They're a solid lesion. This is true. And that's the spleen. And what does this tissue look like?
Spleen.
It looks like the spleen, exactly. And it is. It's extrasplenic tissue. So you can get these things, and they're known as splenules, accessory spleens, splenunculuses, or splenunculi in plural, or they can be called a supernumerary spleen. So it's splenic tissue outside the spleen, usually 1 to 3 centimeters in diameter. Sometimes they're congenital. Trauma can actually cause it. So if you damage the spleen, you can get some growth of splenic tissue outside of the spleen. And they're more common if you have a big spleen. So splenosis is post-traumatic. And so if you rupture your spleen, some of that splenic tissue can actually grow on the peritoneum. So you can grow some of your spleen back, but it also can look like metastatic disease adherent to the peritoneum. So if you have somebody who's a couple of years post-trauma and they rupture their spleen, they can actually have these weird little splenosis where there's some of their splenic tissue regrows right up against the peritoneum. You can also have cysts within the spleen. And just like our polycystic kidney disease goes to the liver, it also can have involvement of the spleen. So the spleen is involved a little bit less often, but if you have somebody with the autosomal dominant polycystic kidney disease, you can also see a whole bunch of splenic cysts as well. So you can also see post-traumatic or post-infectious or post-infarct. You can see cysts as the infarct deteriorates. It may actually look cystic. We talked about polycystic disease. Congenital is actually fairly rare in splenic cysts. You can also have parasitic, and then mimics of cysts. Again, vascular lesions. You can actually see an aneurysm there as well. So solid or target lesions, can apply some color, see what they are. Typically, they can be most common. A solid lesion is going to be a hemangioma, can be a hamartoma, can be a lymphoma, it can be metastatic disease, infarcts, abscesses, sarcoids, all sorts of things, and hematomas. So if you have somebody who doesn't have trauma and they have a lesion in their spleen, it's most likely a hemangioma, but again, you would want to make sure that it's not a met from somewhere else or an abscess, depending on the clinical situation. Scanning through, we have our spleen. This is another example. You'll notice right there, there's a solid lesion. And unfortunately, I don't know what that is because this guy got transferred out and we didn't actually find out what that solid lesion was. I don't know if it was something benign or something bad. How about these little guys? Spleen. they came from the southwest, what might you think they had? And I'll tell you, this is not air. So these are nice. They're kind of round, really hyperechoic. Coccidio, it's actually not the stomach because the kidney is down here. So this is actually the spleen, but that's a really good point because you could think there was something, air bubbles in the stomach, and we'll get to that. But this is actually their granulomas. So you can see there's actually one in the liver here, and then there's a bunch in the spleen. So somebody who's got, somebody who has sarcoid, or somebody who had coccidio or histoplasmosis. So if they were in kind of the southwest and they wound up with histoplasmosis, they can actually have these nice little granulomas in their spleen. So this is someone who came in kind of repetitively and got ultrasounded and scanned. They were a trauma months before, and they actually had, so they had a procedure done. They had coiling done of their spleen. So they had a traumatic splenic injury and they put coils in, and this resulted in a loss of vascular flow to the top half of the spleen. And this person was a prisoner, and they just sort of kept coming back and kept coming back because they were having left upper quadrant pain. And they got ultrasounded and scanned. Well, first they started re-CT scanning them, and then they switched to ultrasound. And eventually this patient she just sort of stopped coming back. I don't know if that means she actually got out of jail or she actually stopped having pain. So not sure about that one. So that would be a post-traumatic and post-procedural loss of blood flow to the spleen. So we're in the left upper quadrant. We've got kidney, we've got spleen, and then what's going on up here? It's nice. So we have these two are kind of the same echogenicity, and then the hyperechoic spleen in the middle. It's actually not blood. And notice here, it almost looks like there's some blood vessels within this. What could be really big and actually cross over the top of the spleen? Yeah, so this is actually an example of extreme hepatomegaly where the left lobe of the liver has crossed all the way over the top of the spleen. You can see the three different parenchyma, the kidney, the spleen, really homogeneous, and then the liver, when you can actually see the vessels within the liver. So this is extreme hepatomegaly where it actually crosses all the way over the top. I see Diane got it. Excellent. And now, Ziad, this is your favorite thing. So we have the spleen here, and then we have this other structure that's got fluid in it. So this was somebody who just drank a couple beers before they came and you did the fast. So this is in your stomach. So you're just too far anterior, and if you angle more posteriorly, you'll find the kidney. But people might think that this is a, free fluid there, and you'll notice it has a wall around it. It's actually a pretty dense wall. You can sort of see the rugae of the stomach, and then you can see that there's fluid in there. So spleens, typically they're homogeneous. They're less than 13 centimeters in length and less than 6 centimeters in thickness or in depth, and that's measured right at the hilum. So some of the things that can cause you to have a big spleen, CHF, portal hypertension, blood disorders, hepatitis, mono, other infections, and hemolytic anemia. Like malaria would be one of those things that could do that, or sickle cell. And then uncommon, if you have somebody with bad glycogen storage disease or myelofibrosis, they can cause that as well. So there's extrasplenic tissue. You can have splenules and splenosis. So the splenules are the nice little round guys, and the splenosis is where it's actually sticking to the peritoneum, and that is usually going to be post-traumatic. You can have cystic lesions. Often these are post-traumatic or post-infection, and it's basically a resolving infarct or resolving infection. Polycystic kidney disease. You can have congenital cysts, but these are pretty rare, much more rare than you would see in the kidney or the liver. Parasitic cysts. You can have mimics of cystic lesions, which would be like the vascular types, aneurysms, and those you want to actually use Doppler for. The solid lesions, there's a whole wide differential. And again, you can throw Doppler on these and see if they fill with color, if they're a hemangioma, but a tumor might do that as well. So again, you're going to want to make sure you send them for a CT to figure out what this lesion is, or they may want to do an ultrasound with someone who's better at differentiating these, but usually you're going to wind up doing a CT scan. And if it's metastatic, you want to make sure you take a look at the liver. And don't misinterpret hepatomegaly. So if the liver actually crosses over, you'll notice a distinct differentiation between the liver texture and the splenic texture. And then the stomach if you're angling the probe too far anteriorly, you'll be in the stomach. If you just angle a little bit more posteriorly, that will get you the view of the kidney, and you'll know that you were just looking at somebody's lunchtime beer. So we talked about the liver and the spleen, and we talked about their normal appearances, and we talked about some of the lesions that you might see and kind of a limited differential that you can develop. So that's kind of all I have. Questions, comments?